So last week we spoke about just a brief review of the anatomy and physiology of the musculoskeletal system. So remember, your skeleton, it provides structure for your body. It provides a safe place for many of your organs to sit in and be protected. For example, the skull protects your brain, your ribs protect your lungs, and also your heart, and so does your sternum protects your heart. Your pelvic girdle protects your reproductive organs, and your bones provide a framework for your muscles to attach. And you need your muscles for you to move, right? So, musculoskeletal, the skeletal provides the framework and structure, and the muscles provide you with the ability to move. We learned about the axial skeleton and the appendicular skeleton, where the axial skeleton is in the center of your body, and the appendicular skeleton include your where your appendages are, or your extremities. We learned about the difference between an osteoclast and an osteoblast. And remember that the B in osteoblast is for build up. The osteoblasts build your bone up. And where is all of this found? In your study guide. So you don't even have to panic. It's all here. Just a quick little review. Okay. We also learned about joints. Joints are where two bones meet, which are very important for movement. So let me get this right. So we learned about joints. It's where two bones meet, and we learned that they meet in what is called the synovial cavity. So a joint cavity is called a synovial cavity, and it's filled with fluid called synovial fluid. And so when you move your bones and it's at the level of a joint, you don't want bone rubbing against bone. That would be extremely painful, and it would make movement very difficult. But bones are able to function properly at the level of a joint because they're separated physically. We can see the bones are separated, and there's a layer of fluid in between as a cushion and as a shock for trauma. And also the bones are lined with cartilage here in this picture. Okay. And we learned that when the joint cavity is infected or inflamed, that's called synovitis. We also learned that there's three types of muscle. So now we know what is a joint. Now we're learning what is a muscle. A muscle is a band of muscle fibers arranged into fascicles. And muscle does need oxygen, a lot of it. And I know I talk a lot, but I just wanted to share, if you're trying to lose weight or become healthy, one of the best things you can do for yourself is A, eat a lot of protein, and B, do strength training like lifting weights. And ladies, let me show you something. Hold on a second. So if you're trying to lose weight or get in shape, one of the best things you can do for yourself is eat a diet that's high in protein, but always check with your doctor, right? But why? Because protein is going to help your body rebuild and build muscle. But you've got to work that muscle out. And so that's for men and women. One of the easiest ways to lose weight is to do strength training with weights. And so for men, obviously, a man would use, a lot heavier weights, but I like these weights. So these are just 2 pounds each, and there's lots of different exercises you can do with them. And so when you work out your muscles, which is called strength training, your body uses more calories to maintain that muscle. So because I eat a diet that's high in protein and I do strength training, I'm sitting down right now. All I'm doing is talking and teaching to you, but my body has to burn more calories to maintain my muscle. You see what I'm saying? And so A lot of people think, oh, the only way to lose weight is to run a lot, do a lot of cardio. One of the more effective ways is cardio is good because it's good for your heart, right? But strength training is very good for your body. And as we get older, we don't want our muscle mass to decrease, and it naturally does, unfortunately. But eating a diet high in protein and strength training will help you to maintain a lean muscle mass. That's what you want. And so a diet high in protein, it's going to be high in chicken, fish, shrimp, healthy proteins. And you want to stay away from white rice and pasta and things like that. So what a typical breakfast would look like for me would be, scrambled eggs, turkey bacon, and fruit. That's high protein, and I'm going to get good vitamins from the fruit. And you can even add in avocado, because if you find that when you eat healthy, you're always hungry afterwards, it's because you're not eating enough fat. So, a really good breakfast: eggs, avocado, turkey bacon, and fruit. So you've got good protein from the eggs and bacon, and good healthy fat from the eggs and avocado. And a good lunch, chicken and a big salad, as much as you want, right? But not a lot of dressing. So high protein and weight and strength training, that is a very effective way to lose weight and to be healthy. So I just wanted to share that with you guys because I always want you to be healthy. Because I don't know why. Nurses, we never take care of ourselves. We always take care of everyone else, but we don't take care of ourselves. Okay, so there's three types of muscle. You have skeletal muscle, smooth muscle, and cardiac muscle. So skeletal muscle, that's the only muscle that you can control. Thank God. Okay. Smooth muscle is everywhere in your body. I mean, it lines your intestines. That's what lines your bronchioles, for bronchial constriction, bronchodilation. So smooth muscle, thank God it's involuntary. You don't have to think about opening your bronchioles and your airways, and you don't have to think about peristalsis, making food move through your stomach and intestines. It's just going to happen on its own. Cardiac muscle, that is, the myocardium that, causes your heart to beat and relax. Thank God you don't have to think about that, because that would be a lot of work. Then we learned the difference between a tendon and a ligament. So remember, this is just a review of what we went over last class. And it's a really good foundation for understanding certain elements of safety, and a good foundation for answering NCLEX questions correctly. So a tendon versus a ligament. A tendon attaches muscle to bone. So this right here, this white silvery band, is a tendon. So when you're cleaning chicken and you are cutting meat off of the bone, you're cutting a tendon, cutting through a tendon. A ligament connects bone to bone. Okay, so this white band here is a ligament, and they usually look like, white and silvery. And so when you're cutting chicken and you're separating the drumstick from the thigh stick, you're cutting through a ligament. Okay, so here is a very popular tendon, the Achilles tendon. If this were to get severed, unfortunately, you could not walk on that foot. Okay. And then we have the tendons of the knee. So these are very important. So I'm going to circle something, and I want you to tell me, is this a tendon or is it a ligament? Let me make that more thick. One moment. So tell me in the chat, what I just circled, is that a tendon or a ligament? It's a tendon, very good, because it connects a muscle to a bone, right? This is your patella, right? Very good. And then what about this right here? Is this a tendon or a ligament? It's a ligament, very good. This is a ligament because it connects two bones together. So this ligament, your patellar ligament, it connects your patella bone, which is your knee bone, to your tibia, which is the larger bone of your leg, okay? So you're like, wow, right? Everything, all of this works together for you to be able to bend your knee. And you don't even have to think about it, right? We have so much to be thankful for. So then we got into musculoskeletal injuries. We learned the difference between a strain and a sprain. So a strain is an injury to a tendon. So just think the T in strain is for tendon. So as we can see, this tendon here, which connects the calf muscle to the back of your leg, your back of your heel, okay, this got injured. Then we learned that a sprain is an injury to a ligament. So this ligament here connects the bones of the fibula, okay, to the bones of your ankle. And so as we can see here, probably this person, when they stepped wrong at an improper angle and they tore their ligament. And so this is what we would call a sprain. And so for both of these, we learned about rice, okay? And so that's on page, one moment. That's on page 237 of your study guide. So make sure you know rice. Rice is rest, ice, compression, and elevation. So that's going to help decrease swelling and pain, okay? For homework, you were supposed to read through diagnostic tests on page 236. So if you did not do that, please do that. And make sure you know that we use a bone scan to diagnose bone cancer. At the bottom of page 237, make sure you know that for carpal tunnel syndrome is a compression of the median nerve in the wrist. And the most beneficial treatment for carpal tunnel syndrome is nighttime splinting. The final subject we got into last class was fractures. Fractures is a break in the continuity of bone. So a break in continuity of bone can be caused by trauma, twisting, indirect loss of leverage, bone decalcification. A disease process can cause a fracture. For example, someone with bone cancer like multiple myeloma, that can cause the bone to break. So their bone didn't break because of trauma or because of falling. Their bone broke because they have a disorder. So that would be called a pathological fracture. So make sure, it was part of your homework to review the different types of fracture. So, you have a simple closed fracture where the bone is broken, but the skin is closed. That's why it's called a closed fracture. Okay. Then we have comminuted fracture where the bone is broken into small pieces. Complete fracture, the bone is broken into two separate parts. Compression fracture where other bones crushed a bone and that's why it broke. Depression where it, inverts, it goes inward. Green stick fracture, one side of the bone is broken, the other is bent. Okay, so this side is broken and the other is bent. Impacted fracture where bone fragments are driven inwards. An incomplete fracture is when the bone is broken and the other side is not. So it didn't break clean. Oblique, it broke on an angle. Open compound fracture, this is the most important one, where the bone broke and it's sticking through the skin. And the number one priority for the nurse is to prevent infection. And we're going to learn, because osteomyelitis is a very, very severe infection that can lead to sepsis and death very quickly, because the bone has access to a large blood supply. It's very vascular. It's very much connected to the blood supply. So it's very easy for a bacteria to hop in and cause a severe infection. Pathological, it's due to a disorder. Spiral, it broke on a spiral. And transverse, it broke straight across. So the most important one is open compound, because the skin is open, and what you're going to do is cover it with a sterile dressing and get them help immediately by contacting the healthcare provider, or if you're outside of the hospital, bringing them to the hospital immediately, because we want to prevent infection. Okay, so treatment of a fracture. So treatment of a fracture, these are different components of treating a fracture that are all essential. So immobilization, reducing the fracture, performing a neurovascular status, the 6Ps, this is essential. Maintaining proper alignment, preventing infection, and pain management and comfort. Okay, so why do we want to immobilize a fracture? So when someone has a fracture, we don't want them to keep walking on it or keep using the area that's injured, because we don't want them to damage it worse. We don't want them to damage that area worse and cause other issues. For example, if they have a fracture somewhere and a piece of bone, because bone that's broken can be very sharp, we don't want them to keep using it and they poke something else in their body and, for example, puncture a lung or cause internal bleeding, right? So it's very important, not only for the comfort of the patient, but also for the safety of the patient, that any kind of trauma, and especially fracture, that area is immobilized. Okay? Another essential component of fracture is reducing the fracture. Reducing the fracture means you put the bones back in place. The fancy, you can say, to restore the bone to proper alignment. And we're going to talk about that in a little bit. Then the 6Ps, which are essential. They are an essential part of your NCLEX repertoire. We're going to talk about that in just a little bit. Okay. Also, maintaining the proper alignment for bone healing. So once we've aligned the bones back in place, which we call reducing the fracture, once we've reduced the fracture, so kind of like if these two pins were part of one bone and the bone is now broken, we have a break in the continuity of the bone, that is called a fracture. Reducing the fracture would be putting it back into place, right? But sometimes that's not enough, because, okay, what's going to make it not go back apart again? And that's where we use certain devices like traction and casts and splints and fixation, okay? So we use different methods and devices and techniques to keep it aligned so that it can heal, okay? Because first of all, if you don't reduce the fracture, the area will never heal. And not only is it enough to reduce the fracture, but you have to immobilize it so we don't cause further damage, and you have to keep it aligned with the proper method. And we're going to learn about that. We have to prevent infection, because remember, the bones are very vascular. Bones have a large and complex blood supply, so it's very easy for infection to occur, and that infection to spread very rapidly and cause sepsis and death. And then also, one of the major priorities is pain management and comfort, because we don't want our patients in pain. So interventions to treat fracture. So reduction is going to restore the bone to proper alignment. So reduction can be open or closed. So closed reduction is non-surgical. So that's when they do it through manual manipulation. So give me just a moment and I'm going to put a video up for you that's going to demonstrate that. Give me just a moment, having a few technical difficulties, but I'll get the video up shortly. Thank you. Okay, so here's a video that's going to talk about closed reduction of a distal radius fracture.
Distal radius fractures are commonly displaced or angulated. If they are allowed to heal in such a position, it may result in deformity and partial loss of function. Pulling the fragments back into alignment is commonly referred to as setting the bone. The procedure is more technically known as a reduction. A closed reduction is when the fracture is reduced without making an incision and exposing the broken bone. The distal radius is generally considered to be well aligned based on certain parameters measured with X-rays. If the fragment is tilted too far forward, it is known as volar angulation. If it is tilted too far backward, It is known as dorsal angulation, which is very common. If it is tilted too far to the side, there may be loss of radial inclination. Sometimes the fracture is shortened, resulting in shortening of the arm. Sometimes the fracture is displaced enough that the bone does not have a chance to heal correctly. If there is displacement or step off along the joint surface, it may result in early wear and tear in the joint, which will cause arthritis and chronic pain. In these situations, a reduction should be performed. A closed reduction is painful, and some form of anesthesia should be provided. This may be done with sedation. It may also be done with a hematoma block. This is when a local anesthetic, such as lidocaine, is injected directly into the fracture hematoma, numbing the painful area. Sometimes the wrist will not relax enough to perform the reduction, even when the patient is sedated. If this is the case, sustained traction across the fracture site may help to fatigue the muscles and the wrist will relax. The reduction itself is performed by pulling the wrist in traction. Force is then applied to push the fragment back into place. It is often necessary to accentuate the fracture while applying traction to free the fragment before pushing it into place. Once the fracture is well aligned, a cast or splint must be applied to hold it in alignment. A sugar tong splint is a popular choice because it can be molded to hold the fracture in alignment, prevents pronation and supination of the forearm, and allows for swelling. The cast or splint is applied using three-point molding. One hand is applied at the fracture site, another distal to the fracture site on the opposite side of the wrist, and an assistant's hand is applied at the elbow. This molds the cast or splint in such a way as to prevent the fracture from moving back out of alignment. When the cast or splint has been applied, X-rays should be obtained to confirm that the fracture is well aligned.
All right, so my favorite video that I love to show, it wasn't working, but basically, does everyone have an understanding of closed reduction? So closed reduction, you are not using surgery to put the bones back together. You're using manual manipulation to put the bones back together. Does that make sense to everyone? Because I just want you to know that if you see that on the NCLEX, so if you see closed reduction, the patient didn't have surgery. They probably got pain medication and sedation, because especially like when it's like larger fractures and trauma, they, got pain medication and sedation. But if you see open reduction on NCLEX, open reduction, the patient had surgery and they are at high risk for infection. Does that make sense to everyone? Okay, so I just wanted you to be comfortable with that verbiage, with that language. Okay, so reduction, closed reduction, it's non-surgical, it's performed by manual manipulation. Open reduction, this is surgical, okay? And so when they do surgery to fix a fracture, to reduce a fracture, usually they're going to use hardware to keep the bone in place. And then there's two types of hardware. So there's two ways to reduce a fracture, and then there's two ways to keep the fracture in place. Okay, so here we have a picture of, now somebody tell me, what is this a picture of? What type of reduction is this? Is this closed reduction or open reduction? This is closed reduction, right? So the patient got pain medication. They might even get sedated. right? Okay, I want to ask you this. What about if your patient, you see they have this x-ray? Could this have happened through closed reduction, or is this definitely only open reduction? Very okay. You've got it. Okay. So that's all I wanted to make sure you know so that if you see those words on the NCLEX, you weren't confused or it didn't make you panic. So this could only have been achieved through open reduction. Oh, they had to open up the patient and surgically align the bones back together, and then to keep the bones in place you use fixation. So reduction is putting the bones back in alignment, and fixation is keeping them in alignment with hardware and devices, with rods and pins and screws. Okay, so there's two types of fixation, internal and external. So this is what we call internal fixation. Internal fixation is the application of screws, plates, pins, and rods. Okay, very good. This is internal. And then this is external fixation. So external is you don't need an x-ray to see it. It's you see it right when you walk in the room. Okay. So this is external fixation, and these are all internal. I know that, this is sticking on the side, but the person's skin is going to be covering, the person's muscle and fat and skin is going to be covering all of this, right? So if you need an x-ray to see it, it's internal fixation. All right, so last time I'm going to repeat it. I just want to make sure that these words don't make you afraid on the NCLEX. Reduction is restoring the bones back to proper alignment. Closed reduction, non-surgical. Open reduction was surgery. Once they do open reduction, they have to keep the bones in place somehow, right? And so they do that with fixation, and fixation is the hardware that keeps the bones in place. And there's internal and external. So, and remember, the different devices are screws, plates, pins, and rods. Next up is traction. So traction is using weights and pulleys to reduce and immobilize the fracture. So we want to reduce the fracture, which is bring it back into alignment. Okay, so this person obviously, what bone or bones do you think this person broke based off of the picture? Mm, the femur is up here, so I don't think it's the femur. Maybe the fibula or the tibia, but yeah, and it could be the tibia or the fibula. Very, very good. So they're lower leg bones, right? Very good. So remember, traction uses weights, so you can see the weights here, okay, and pulleys and ropes, okay. And so this setup is set up in a way where it's pulling on the leg in a way that it's keeping the broken bones in proper alignment, and also the patient can't move. It's immobilizing the patient so that the fracture can heal. Okay. And when we keep broken bones in proper alignment, we reduce muscle spasm. So one of the major causes of pain after a fracture, besides what caused it, right? Like the fall could have been painful, or the car accident that caused the fracture could have caused a lot of trauma that was painful. Besides that is when bones are out of alignment, the muscles start spasming to try to bring the bones together themselves, but they can't. And so that's very painful. Muscle spasms are probably one of the most painful parts of having a fracture. And so something like traction is going to keep the bones in alignment and reduce that muscle spasm. So we can have skeletal traction. So skeletal traction is when the devices, like the pins, the wires, that they go through the bone, okay, and then using a pulley system with the weights to reduce the fracture. So as you can see, they're using a specific amount of weight and force to keep that leg in that exact position, because in that position, you can see the fracture is reduced. The bones are aligned. And remember, the fracture is only going to heal when the bones are aligned. So that was skeletal traction. The rods and the pins are going the pins are going straight through the bones. Or you can have something called skin traction, where there's nothing inside, sticking inside the patient, but we're using like a boot or a sling. And so this is where we introduce Buck's traction. So Buck's traction is a type of skin traction. Okay, so there's nothing sticking inside the patient here. It's a boot applied and a weight that's keeping it in alignment so the fracture is reduced and immobilized. Also, we can use casts. Casts are another way to immobilize a fracture and maintain correct alignment. So your number one priority after cast placement is do not, so when they put the cast on, it's usually going to be very wet afterwards, and it's going to become harder as it dries. Do not press down on a wet cast, because you don't want to create a dent, because it might feel soft and normal now, but as it dries, it can get harder and harder, and that dent can press down on a blood vessel and compromise circulation and blood flow. Our number one concern with a cast is that it can be too tight and cut off blood flow, and that person lose that extremity. So we're always going to do the 6 P's on an extremity with a cast, and we're going to learn about the 6 P's. You always want, so we're on page 239 of the study guide. You always want cast cutters at the bedside. You always want cast cutters at the bedside for a person with a cast, so that you can remove it if you believe that that extremity has a circulatory impairment, that blood flow is off, something is not normal, that hand is very pale and cold, and I can't feel the pulse that I felt there an hour ago, so that you can cut it off immediately and notify the healthcare provider. So we're going to get into some priorities here. So external fixation, it stabilizes the fracture. And let's see. So here's an example of a fracture with external fixation. So as you can see, what type of reduction did the patient have to have all of this done? And you kind of have the proof right in your face. Oh, what did I do? What kind of, let me put the picture back up. But what kind of reduction did the patient have to have? Not closed reduction. They have a surgical scar right here. Open reduction. Very good. And just remember, open, they had to open the patient surgically, right? So they definitely did surgery on this patient. And here's the surgical incision, right? With liquid stitches. And then they applied the external fixation. So I want you to know this for NCLEX. And An adjustable external rod is outside the skin and holds the pins and devices in place. So they use the pins and plates above and below the fracture to keep the fracture reduced, which means aligned. And then they put the devices externally to hold those internal devices in place. Um, some benefits of external fixation are that they allow for it allows for early ambulation, and it increases patient autonomy or independence. However, the number one priority for external fixation is to prevent and monitor for pin infection. So some signs of pin infection. So redness, drainage, pain, swelling, fever, the pins becoming loose. We don't want the pins becoming loose, because if the pins become loose, they're not holding the fracture in place. And if we're not holding the fracture in place, the bones are not aligned. The muscles are going to spasm. It's painful to the patient, and the area cannot heal when the bones are not aligned. So why is pin infection bad? So pin infection is going to cause swelling, and that can make the pins become loose, and it causes the bone to become displaced. So that's why we provide sterile pin care, and we're monitoring and reporting purulent drainage with any foul odor, redness, warmth to the sites, any changes in appearance that we're worried about. On page 240, Buck's traction, homework, you must memorize Buck's traction. You have to be very strong in Buck's traction. So Buck's traction is a type of skin traction. Remember, it is not, we don't have pins inside the patient necessarily. It's a boot, and it's used to immobilize a broken hip. It is used to stabilize a fracture before surgery. So after a fall or some type of trauma and the hip is broken, before surgery to reduce the fracture, they will use Buck's traction. The traction boot is on the side with the broken hip. Then a weight is connected to a rope and pulls on the boot to keep the fracture reduced. The patient should be in the center of the bed supine. Nursing priorities. Buck's traction, you have two things to check every 2 hours. Buck's traction, you have two things to check every 2 hours. Buck's traction, you have two things to check every 2 hours. Skin and your 6 P's. So, impaired skin integrity. Pressure from the boot can cause the skin to break down rapidly. So you want to do skin check every 2 hours. You can loosen the straps on the boot if it is too tight, or you can tighten them if it's too loose. But if you loosen or tighten the straps, you have to check the 6 P's in 30 minutes, because you just want to make sure that we have not made any changes that are affecting blood flow to the extremity. And that's where the 6 P's come in. So please write this down. I'm going to give you 5 minutes to write this down, and then we're going to talk about it, and then we're going to jump back in to Buck's traction. All right, guys. So let's talk about the 6 P's. This is essential for you to be successful on the NCLEX, okay? So, pain, pallor, pulselessness, polar, paresthesia, and paralysis. So this is what we call the neurovascular assessment. So it is a way to assess the neurological and circulatory status of an extremity or an area. So when would you use the 6 P's? So well, let's talk about what the 6 P's are first, okay? So first of all, why do you care? Why do you care about that? So when someone has a cast on, or when somebody has a fracture to an area, you want to make sure that that area is still able to function neurologically and is getting good blood flow. Because without good blood flow, the tissues are going to die and that person could lose that extremity. So, first of all, pain. Pain with a fracture or injury is normal, but if the pain is severely abnormal to what is expected, or we're treating the pain, but still the pain persists, the pain is constant, it's unchanging to position or movement, you want to let the healthcare provider know that because that's not normal, okay? Pallor, if that extremity is pale or it's losing color or there's no capillary refill, that is a problem. That means that there could be poor blood flow, poor circulation, poor perfusion, pulselessness, if we lose a pulse. So if you have the pulse there and now it's not, that's a medical emergency. You have to get the Doppler, try to find the pulse, and if you cannot, you have to let the healthcare provider know immediately so that that patient is not at risk for losing that extremity. Polar, that means the skin is cold, and you can always compare it to the other extremity, so that can kind of give you a guideline. And also the color too, use the other extremity to compare. And polar is also called poikilothermia, but I always say polar. And then paresthesia is, do they feel any numbness like pins and needles? That's definitely a sign that um, they could have impaired circulation. They feel that numbness feeling. And then paralysis, where they just cannot move that extremity and they could before, right? So that's a problem. So these are things that you're checking, and if they are abnormal, you let the healthcare provider know immediately. So when would you want to perform? In what situations would you want to perform the 6 Ps, which is also called your neurovascular assessment? Okay, so you would want to perform this for a patient with a cast, burn on that extremity, intraction, in a restraint, or any kind of fracture or injury to that extremity. Okay, so why the cast? Because the cast can be compressing on blood vessels, and that can impair circulation. And the only way we're going to pick up on that is we're going to do the 6 Ps, and we're going to see, is the skin pale? Have they lost a pulse? Is it cold to the touch? Do they have numbness and tingling, or they can't wiggle their fingers the way that they used to, or wiggle their toes? And so you want to do this often so that when there's a change, you can pick up on it quickly. This is not something you do once a week or once a shift on a patient like this. No, you would want to definitely do one in the beginning and, get a feel for it. If it's a new injury or they have not been doing so well, you might have to do it every 15 minutes, every 30 minutes, every hour, every 2 hours, every 4 hours. It all depends on the needs of your patient, but it's never wrong to do it too much. It's better to do it too much and catch a problem or nothing's wrong then you don't do it enough and something was wrong and that person loses their whole foot, right? So let's go back to Buck's traction in the study guide. So you have two priorities to check every 2 hours for Buck's traction: skin and the 6Ps. So at minimum every 2 hours and more often as needed. So make sure you read Buck's traction on page 240 for homework. Next up is Cole's fracture. Okay, so Cole's fracture is a wrist fracture, and just give me a moment because I know I'm not crazy, or maybe I am, but okay. I'm gonna put a picture up of Cole's fracture to show you the dinner fork deformity. One moment. Okay, so this is so Cole's fracture is a wrist fracture. Okay, and it usually happens to women over the age of 50, and it's related to osteoporosis because as we age, our bone mass decreases, and especially someone with osteoporosis, which we're going to learn about a little bit later in lecture, and so they're more at risk for fractures. So when they fall, they usually try to put their arm out to break the fall, and then they break their wrist, and it results in Cole's fracture or a dinner fork deformity. So I just want you to know, if you see Cole's fracture on NCLEX, I want you to think dinner fork deformity. And nursing interventions, you would do your 6Ps, you would check capillary refill, and just know that there's going to be swelling. So as we can see, the area looks very swollen, and the issue here is that the swelling can compress arteries, and the artery that will decrease blood flow to the area, which can lead to compartment syndrome. So Cole's fracture, compartment syndrome. Cole's fracture can lead to compartment syndrome. And so what we're going to do is we're going to do the 6Ps. We're going to call the doctor for an emergency reduction of the fracture, pain medication, ice pack to reduce the swelling, and we want them to move their fingers because as they move their fingers, this is going to decrease the swelling and increase blood flow. So that's on page 241, word for word. You have to read the study guide if you want to be successful on the NCLEX, okay? Next up, we're going to move into some complications of fractures. So fracture complications. First up is fat embolism. So the long bones have yellow marrow, which contain fat. And so when the long bones like the humerus, the arm bone, or the femur, the thigh bone get broken, fat can escape and then get stuck or obstruct an area, and this can lead to heart attack or PE. So if a patient with a long bone fracture develops sudden chest pain and shortness of breath, that is usually because of a fat embolism. Unfortunately, fat embolisms are highly fatal, and there's usually not much that can be done. Compartment syndrome. Now, this is big, okay? Compartment syndrome can definitely lead to loss of extremity. So, compartment syndrome is when swelling from a musculoskeletal injury compresses the blood vessels that bring oxygen to the muscle fibers. And so, because the arteries are compressed, We have decreased blood flow to the muscle, and that is going to lead to death of the muscle tissue and irreversible neurovascular damage if not treated within 4 to 6 hours. So let's take a look at this picture. So here we have a normal view where we have a transverse section of the leg, of the thigh, and we can see muscle. And we can see in between the muscle, we can see the blood vessels. And these blood vessels bring oxygen and nutrients to the muscle fibers, and they bring away CO2 and waste. However, if an individual has a trauma or an injury, we can see that there's swelling in the muscle compartment, and that swelling, you can see it compresses the blood vessels. So just let me know in the chat, yes or no, if you can see how swelling from the injury has compressed the blood vessels. Let me know. So look at the top picture versus the second. Here we have a normal cross section and the arteries are open. There's nothing compressing them, but here they are completely compressed. Let me know in the chat. Okay, so the goal in the treatment of musculoskeletal is to recognize the signs quickly. So that's why we're doing 6Ps on patients with trauma and injury, especially to an extremity. Okay, and the goal is to release the pressure that is on the compressed arteries. Okay, so assessment of an individual with acute compartment syndrome, the area feels tight, wooden, hard, like that extremity is going to feel hard when you touch it. Their pain is not relieved by, Motrin and NSAIDs and things like that. Paresthesia, numbness, and tingling. They're going to have paralysis. They won't be able to move that extremity, or they'll have reduced range of motion. Their extremity is going to be pale due to reduced blood flow, no pulses, and pain and paresthesia. So pain and paresthesia are going to be early symptoms. Treatment is emergency fasciotomy and maybe a wound vac. So a fasciotomy, they're going to cut into the compartment, and it's not pretty. It is not pretty. This is a fasciotomy. But you can see how swollen that extremity was. And they're going to cut into the compartment to relieve that pressure so that that pressure is off of the blood vessels, and now the muscle tissues can get perfused. All right, other complications of fractures, infection, and osteomyelitis. So that's why we want to prevent infection. So infection control is a number one goal, is a number one or one of the major goals in caring for patients with musculoskeletal injuries. Definitely we want them to be safe and comfortable, and we want to prevent infection. Okay, fractured hip. Fractured hip on page 242, please read that section very well and make sure you know that after a fractured hip, an elderly patient is more at risk for post-operative delirium. And so that can lead to confusion, altered mental status, and they can try to get out of bed and they'll fall again and re-break the hip, right? So just make sure you know, for some reason, after surgery for a hip fracture, elderly patients are more at risk for post-op delirium. So we want safety as the number one goal, okay? So please, this section for fractured hip on 242, I know you guys have the study group. Please review it, review it, review it. Remember, it's your responsibility to read the entire chapter for what we're learning. I'm touching on the high points. Also, make sure you read about amputation of a lower extremity. All right. Now we're going to take a 5-minute break, and when we come back, we're going to get into musculoskeletal disorders. Guys, so, musculoskeletal disorders, rheumatoid arthritis. So, rheumatoid arthritis is a chronic systemic inflammatory disease. So, it leads to the destruction of connective tissue and the synovial membrane within the joints. It weakens the joint and leads to permanent deformity of the joint. So, rheumatoid arthritis is an autoimmune disorder. The person's own body is attacking the joints, and it affects the smaller joints. So it leads to physiological deformity. As we can see, physiologically, the person cannot use their hands the way that they would normally to open a jar or open a door or even to put a seatbelt on and take it off. And psychologically, because they're unable to perform their ADLs and previous tasks, they feel ineffective in their performance. So we're dealing with body image disturbance, we're dealing with, loss of function, ineffective performance. So, assessment, it's chronic pain and swelling that is symmetrical. It affects the small joints of the hands and feet. It's morning stiffness. This is what I need you to lock in for NCLEX. Morning stiffness that lasts 60 minutes or more, an hour or more. Okay, that's how you're going to tell the difference between RA and OA on NCLEX. So rheumatoid arthritis versus osteoarthritis. Okay, RA, the stiffness is in the morning for 1 hour or more. Okay, also for rheumatoid arthritis, fatigue, limited range of motion, and their labs are going to show elevated erythrocyte sedimentation rate or ESR. So anytime erythrocyte sedimentation rate or ESR is elevated, that automatically means inflammation. Osteoarthritis. So osteoarthritis, which we can see here in this picture, osteoarthritis is a progressive deterioration of the cartilage. So let's take a look at this picture. So here's a normal joint. So we have a healthy separation between the bones and we have cartilage. Osteoarthritis, the cartilage deteriorates. It's a progressive degeneration or deterioration of the articular cartilage. And so bone is rubbing against bone. So it's very painful. Osteoarthritis affects the larger joints, okay? Like the knee and the hip. So on page 244, it tells you the major differences between rheumatoid arthritis and osteoarthritis. So rheumatoid arthritis is an autoimmune disorder. Osteoarthritis is a degenerative disorder, and it causes bone to rub against bone. So what joints are affected? Rheumatoid arthritis affects the small joints of the hands and feet. Osteoarthritis affects the larger joints, the weight-bearing joints like the knee and the hip. Rheumatoid arthritis, the stiffness is for 1 hour or more in the morning. Osteoarthritis is for 30 minutes or less. Also with osteoarthritis, the pain will get worse when they begin bearing weight because it affects the weight-bearing joints. So treatments, NSAIDs, which are nonsteroidal anti-inflammatories, steroids, and something called DMARDs, disease-modifying anti-rheumatic drugs. So your adalimumab, which is Humira, your etanercept, which is Enbrel, and methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Okay? So this is all in the study guide for you. You just got to review it and be comfortable with it. But what I would focus on for RA versus OA is knowing which joints they affect and when the stiffness, how long the stiffness lasts. That's what's going to tell you the difference. Osteoporosis. So, osteoporosis is a metabolic disease characterized by bone demineralization with a loss of calcium and phosphorus, leading to fragile bones and risk for fractures. Osteoporosis causes a loss of bone mass. So, your number one priority with osteoporosis is safety, okay? Because the client with osteoporosis is at risk for pathological fractures. So, treatment, calcium and vitamin D, this helps to maximize bone growth and bone integrity. And bisphosphonates. Bisphosphonates help to stop the destruction of bone. And so, two examples I want you to know for NCLEX, alendronate and ibandronate. What you have to know about these medications is how to give them. You have to give them and take them in a very specific way. So please, please, please memorize it. You have to. How do you give alendronate and ibandronate? They have to take it first thing in the morning on an empty stomach. Drink a full glass of water. Then they cannot eat anything and must stay sitting up or standing up for 30 minutes if it's alendronate or 60 minutes if it's ibandronate. So if they have issues swallowing or cannot stay sitting for 30 minutes or an hour, they cannot take those medications. Okay? So please memorize that. Number one priority with osteoporosis is safety because they're at increased risk for fracture. How do we treat it? Calcium, vitamin D, and biphosphonates, and memorize the specific instructions on how to give them. Next up is gout. Gout is a systemic disease in which uric acid crystals deposit in the joints and other body tissues. So basically, gout is caused by elevated uric acid levels in the body. And the diet they need to follow, this is what you need to memorize, is a low purine diet. So what foods do they need to avoid? They need to avoid foods that are high in purines, which includes alcoholic beverages like wine, beer, and liquor, anchovies, sardines, mussels, scallop, trout, bacon, turkey, venison, and organ meats like liver. Assessment of gout, painful red swollen joints, especially in the big toe. When they come up, they call it a gout flare, like a flare up, and it often happens at night. Treatment, NSAIDs, steroids. So NSAIDs will provide pain relief. The steroids would reduce inflammation in the joints. And certain medications reduce uric acid production, allopurinol and colchicine. Some people say colchicine when they say colchicine, but all right, musculoskeletal medications. So I want you to know this. So these are the muscle relaxants. The other medications that we've talked about, they were specific to the disorders like gout. We just learned about two, and we learned about alendronate and ibandronate for osteoporosis. And then in general, I want you to know about skeletal muscle relaxants, baclofen, cyclobenzaprine, methylcarbamol, and tizanidine. So if you see those are muscle relaxants. And you have two priorities as nurses. Your number one priority is safety because they cause dizziness and drowsiness. And number two is to monitor liver function tests to make sure that they don't affect the liver or impair the liver. Some other medications, I'm going to put this up and then I'm going to give you a moment to write this down and then we're going to talk about it. So I want you to also know analgesics for musculoskeletal. So I want you to know the difference between non-opioids and opioids. So I'm going to give you a moment to write this down so that you can study this week, and then we're going to talk about it. So I'll give you 5 minutes to write this down. All right, guys. So analgesics are what we call pain relievers or pain medication. So non-opioids and opioids, and this is just a very basic breakdown. There's so much more to this, right? But this is just a starting place. So non-opioids, you can break it down into NSAIDs and Tylenol. Okay, there's a lot more to this. I promise. This is just a very minimal breakdown, okay? Because there's other medications not on here like tramadol and things like that. So, something that is a non-opioid is not a narcotic. It's not a controlled substance, okay? So, NSAIDs stand for non-steroidal anti-inflammatory drugs. And they are analgesics and also an antipyretic. So analgesics, they relieve pain, and antipyretic, they reduce fever. So you have acetylsalicylic acid, which is ASA or aspirin, ibuprofen, which is Motrin Advil, naproxen, which is Aleve, and diclofenac, which is Voltaren. Make sure you know that NSAIDs can cause GI bleed, and you have to take them with food. Also, if the person has kidney problems, they cannot take NSAIDs because NSAIDs would worsen kidney function. Then we have acetaminophen Tylenol. This is what we call a COX-2 inhibitor. It is also an analgesic and an antipyretic. You cannot give it to a patient with liver issues because it will worsen liver function. Then we have our opioids, which are our narcotics, morphine, hydromorphone, which is Dilaudid, oxycodone, you have instant release, IR, and then you have ER, which is extended release, which is Oxycontin. You have hydrocodone, you have codeine, you have fentanyl. And make sure you know that opioids can cause respiratory depression. So we always have to assess respiratory rate before and after giving them. Also, make sure you know anytime a medication is extended release, we cannot chew it. So if you give a patient Oxycontin is usually given every 12 hours, but check the order. It's usually given every 12 hours because it releases slowly in the body to release the medication over time. And this is for more patients with like chronic pain problems. And so what we have to know is that if they chew Oxycontin, they can die because they'll be getting 12 hours worth of narcotic instantly, right? So just those points of education. So as you're receiving an order, if you receive an order for oxycodone, is it IR, instant release, or extended release? And if it's extended release, if your patient cannot swallow, then they cannot get the medication because we can't crush Oxycontin. We can't crush extended release medications. We would have to go to the doctor and ask for another order, another form of the medication. All right, guys, so that's musculoskeletal. It's really straight to the point. So you have a lot of studying to do. So go back through the study guide and please make sure that that you have read the whole chapter, Module 7, review the lectures, and study. And then if you have a question bank, which I highly recommend, do about between 75 to 100 questions on musculoskeletal of any Q bank that you have, and that should prepare you well. All right, guys, so thank you so much. I will see you next week, and next week we're going to be doing Module 8. Module 8 is a lot. It is endocrine. Endocrine is very, very complicated. It is a lot because it's hypothyroidism, hyperthyroidism, Addison's disease, Cushing's, right? Hyperparathyroidism, hypoparathyroidism, diabetes insipidus, SIADH, right? So it's a whole bunch of disorders of this is too high, this is the cause, these are the symptoms, medications, this is too low, this is the cause of it. So it's a lot. So you want to make sure you're coming in for module 8 like ready, that you have studied module 7, you've done questions, and you're ready to move forward. I'm telling you, because module 8 is brutal. And then after module 8, Oh, and then I believe module eight also has oncology in it as well, and hematology. So, anyways, module eight is heavy, right? And then module nine is OB, and then module 10 is peds, module 11 is mental. So we're going through, we're almost done. So please really take the time and every day try to devote at least an hour to review these things. And it is an investment in your future so that you can pass the NCLEX the next time you go. God bless you guys. Thank you. And I will see you next week. Have a wonderful day.